All right, you guys, the next part of our lecture, we're going to talk about cleft lip and palate. Cleft lip is an obvious facial defect of the lip. It can be unilateral or bilateral. There are some figures on page 1209 in chapter 41. Cleft palate, you would need to palpate inside the infant's mouth to detect a defect in the soft and or hard palate. These may appear separately or together. The major problem with feeding is noisy sucking, swallowing of excess air, and they are prone to aspiration. The other issue is parent-infant attachment may be adversely affected due to loss of that perfect infant and multiple hospitalizations. We see a lot of other problems with cleft lip and palate. It could affect speech, nutrition, dental problems, ear infections, hearing loss. I already said that they were prone to aspiration. The treatment is surgery, Z-plasty. We typically fix the lip first, then the palate. We like the palate fixed around 12 to 18 months. That way, hopefully their speech won't be affected adversely. Cleft lip surgery, the first surgery is around 3 months of age. And again, we want to get that done as soon as we can to help them suck properly. Cleft palate is typically done in stages. Again, the initial repair for cleft palate is around 4 to 6 months. And then hopefully by 2 years of age, it's closed completely. And again, that is so their speech is not adversely affected. One of the most important things, and we'll talk about it when we get there, is after surgery to protect that suture line. All right, some of our issues with cleft lip and or palate: altered nutrition, less than body requirements related to a physical defect. And again, this is a structural defect, as how it's classified. Altered parenting related to birth of child with an obvious facial defect. And then knowledge deficit, actual or potential, related to all of the treatments and the follow-up. Again, there could be multiple hospitalizations due to multiple surgeries. It'll depend on the degree of the defect. All right, let's see. Our first goal here is to maintain adequate nutrition. Preoperatively, you'd want to encourage parents to watch the nurse feed the infant and then teach them proper feeding techniques. If you guys can think back to our Failure to Thrive lecture that we actually got to do face-to-face in our first week, we talked about how as nurses, how we model the behavior we want the parents to emulate. So again, we take over feeding and then we transition to the parents feeding while we stay there, making sure they're doing it correctly, offering encouragement and offering suggestions for issues. There's a lot of different things that we can do to help feed these kids to maintain adequate nutrition. There are different types of feeders. One is a Breck feeder, B-R-E-C-K, and that just makes sure the formula is deposited at the back of their tongue. Make sure that we feed slowly with the child in a sitting position. We may need to burp them more frequently. Don't forget they're taking in more air. We need to rinse the child's mouth with sterile water after feeds to prevent infection. Making sure we are maintaining the child's weight, making sure we're meeting those sucking satisfaction needs. Cleft lip, cleft palate, upright position or vertical. Cleft palate, breastfeeding is difficult for kids that have a cleft palate, but we still encourage the moms to breastfeed. A good alternative is having them pump so that they're meeting the nutritional needs and that the breast milk is being deposited into the proper position so they don't aspirate. Our goal to maintain adequate nutrition. Now let's focus on postoperatively. Like anybody, postoperatively, we would begin with clear liquids when the child has fully recovered from anesthesia. Monitor daily weights while they're in the hospital, and then make sure the parents are monitoring the weights at home. If not daily, then weekly. No sucking for either a cleft lip or palate after the surgery. Again, you want to protect the sutures. There are different things we can use to feed them. Obviously, if they're not sucking, there is a wide bowl spoon or a plastic cup. Some things we want to do after surgery, again, protecting the suture line, don't put stress on it. So you want to make sure that we prevent crying, because crying puts stress on that suture line. We don't want the kids touching their face, so we can actually put elbow extenders on them. Picture them looking like little T-Rexes and their hands can't touch their face. Again, we need to protect that suture line, keeping everything intact. Another goal is to promote parent-infant attachment. Again, you would want to show no discomfort when handling the infant, and you want to convey acceptance. Stay with the parents the first time they see or hold the infant. You want to offer positive comments about the infant. Oh, you know what beautiful brown eyes your baby has. Oh, look at all that curly hair. How pretty. So again, just make sure you're reinforcing other positives. You want to make sure you're giving positive reinforcements to the parents' initial attempts at parenting and at feeding. You want to encourage the parents to assume increasing independence in the care of the infant. Okay, so make sure that the parents are eventually taking over everything that you're doing. Our last goal is health teaching regarding feeding. And for long-term follow-up care, lots of referrals. Remember in the beginning, we talked about all of the issues that these kids could have. So we want to do a referral for speech, dental, hearing, social services, community health nurse, disabled children's services for financial assistance. There's tons of support groups. You could refer the parents for genetic counseling services. Encourage parents to promote self-esteem in infant and child as the child grows and develops. So again, hopefully this child is being raised in a very positive and nurturing environment. If we do all of that, we should have adequate nutrition for our infant. And again, don't forget the whole purpose of our infancy and childhood is to grow and develop properly. So again, we need adequate nutrition to grow at a normal rate for their age, and if they're doing that, they're going to develop properly. Again, we need that parent-infant attachment to form so they can grow and develop, and then we want our parents to verbalize confidence in their ability to care for their infant. We want to make sure they're comfortable going home. We want to transition that care so they're doing everything appropriately. All right, the next thing that we're going to talk about is GERD. It's classified as a structural disorder. GERD is self-limiting and resolves by the end of the first year of life, typically. We'll talk about what it looks like in an infant and an older child as well. It can result in failure to thrive, bleeding, and difficulty swallowing. An infant, what the picture of GERD would look like in an infant is forceful vomiting, excessive spitting up, irritable, excessive crying, and again, we could see blood in the stool or blood in their emesis as well, again, from that constant irritation. Gastric esophageal reflux disease disorder, you could see it as GER, just gastroesophageal reflux. Our older kids will complain of heartburn, abdominal pain, difficulty swallowing, and they could just have a chronic cough as well. Some of the labs that we would look at, electrolytes can change with vomiting. So let's take a look at our potassium, and let's take a look at our pH and our bicarb as well, what's going on with our ABGs. And then let's take a look at our sodium. That'll tell us about our fluid status of our patient. The treatment will depend on the severity. We could see small frequent feedings with thickened formula, head of the bed up 30 degrees after feeding. Some providers recommend the prone position for sleep, severe cases only. Some of the meds that we could use are a histamine receptor antagonist, such as your Tagamet or Zantac or ranitidine, or your proton pump inhibitors, your pantoprazole or your Protonix, Prilosec. So we could see some meds on board as well. The big thing that we do need to monitor for is pneumonia. We could see some of this reflux getting into the lungs, so we would have pneumonia. And then again, failure to thrive inability to eat due to erosion. If we don't get those gastric secretions under control, they will erode, and then we'll really get into another set of problems with that.